All right, good afternoon and welcome to today's Kirklees Health and Wellbeing Board held on Thursday, 24th of November 2022. Welcome everyone. Can I remind everybody that this is a webcast meeting and recorded? And could I ask that board members keep their cameras on, please, but other people in attendance, if you turn your camera off until a point where you're going to present. If anybody wants to speak or ask a question, could you put it in the chat bar, please, so I can see it there? And we'll move on from there then. So, membership of the board, item 1, Jenny, have we any apologies?
Yes, Chair, we've received apologies from Councillor Khan, Mel Meggs, Rachel Spencer-Henshaw, Karen Jackson, Ruth Buchan and Len Richards.
Okay, thank you very much. Can I ask, is anybody here substituting for a board member? Could you tell us who you're substituting for? Aha, and see, Lorna, you've got your hand up.
Hi, it's Lorna Peacock, Head of Business Development from Locala, and I'm substituting for Karen Jackson.
Thank you very much. Welcome, Lorna. Matt England.
Thank you. Hi, it's Matt England, Associate Director of Planning and Partnerships, and I'm attending on behalf of Len Richards.
Welcome, Matt. And Emily Parry-Harris.
Thank you, Councillor Kendrick. I'm Emily Parry-Harris. I'm Consultant in Public Health. I'm substituting for Rachel Spencer-Henshaw, but I also have an item on the agenda.
You do indeed. Thank you very much. I can't see any others. So welcome, everybody. If we could go to the minutes of the last meeting, agenda item 2, if anybody has any corrections or any queries about it, speak now, please. Everybody happy with the minutes? I've just one issue that we need to just highlight on page 3, resolution C, was the question about returning unused medication to be directed to Ruth Buchan, just to say that that's still being progressed and will hopefully be fed back at the next board meeting. Is everybody else happy with the minutes? We're all happy with those? We take those as a true record of the meeting then. Thank you very much. Interest, if anybody has an interest that they need to declare, could you please complete the form within the pack and get it to Jenny, who supports this board, as soon as possible. There are no items of a private nature, so the public will be able to view this webcast in full. So agenda item 5, deputations and petitions. Jenny, have we any deputations or petitions?
None received, Chair.
Okay. Item 6, public question time. Have we any public questions?
Again, none received.
Okay. Then we will swiftly move on then to agenda item 7, which is the Inclusive Communities Framework. Joe Richmond is going to speak on this and do this for us. If you have questions, again, can I remind people, could you put a request to speak in the chat bar, please? And I'll move over to you then, Joe, please.
Thank you, Councillor. Afternoon, everybody. I'm Jo Richmond. I'm Head of Communities in the Council. And I'm just going to spend 5 or 10 minutes bringing you up to speed on the Inclusive Communities Framework. I'm going to share some slides, I hope, in a minute. And for those of you who've not had any background on the ICF, the first slide will give you a bit of a whistle-top tour of it. I'll just find... No, we don't want that. So many things open. There we go. Right, I'm not sure what you can see. Can you see that slide, the Inclusive Communities Framework?
Indeed, yes.
Yeah, thank you. Okay, so very brief history, because I know some of you have probably had the most recent history as well, so apologies to that. So the ICF, the Inclusive Communities Framework, started life as a discussion about revisiting our cohesion strategy. Very quickly, talking to partners, listening to feedback from communities, it became about what does cohesion mean to people? What is our role? And how do we support cohesion as an outcome and stop it sounding like a problem to be fixed? So clearly cohesion was taking people down a very singular lens, and we wanted to broaden that out, and communities and partners certainly saw it in a much more holistic way. The conversations with communities became very much about feeling included, and in terms of how people described how they felt included or what needed to be in place for them to feel included. People talked about feeling safe and being able to participate, being able to get a job or training, having good schools, feeling heard, feeling wanted, being able to live a good life, so access services that they needed. So it was very much about how people felt about their local place, their local environment, their connections with other people and with services. And so we started a piece of work across the system, so involving as many people as who wanted to be involved, on how we moved from cohesion in that kind of language to inclusion. So it became clear that a framework was going to be much more useful because that was about doing than, although strategies are about doing, a strategy is also quite a focused piece of work in terms of cohesion and inclusion, and we didn't want it to be a document that sat on a shelf, never got looked at. I'm not saying anybody's strategies that happens to, but sat on a shelf, didn't get looked at, and actually then didn't move us on. So the framework is an active document. It's something that you use and something that can be used with any piece of work in any organisation, large or small. The framework, as I said, has a number of core pillars within it. Those are a starting point, really, that you believe that communities hold solutions. So it's really important that it's a way of doing things. It's not what we do, it's how we do it. So it's the belief that communities hold solutions. It's that belief that it's important to build a sense of belonging, that we want to encourage people to feel included, and how do we contribute to that, and that we care enough to take action to do what we say we're going to do. So those three things, believing, belonging and care, became our underpinning pillars. And in terms of the doing, that became very much about a bit of a self-reflection. So the approaches have been turned into a self-assessment, and I'll share that in a moment. But it was very much about, how do we build a sense of trust? How do we include people? How are we connecting with people? How are we communicating? Are we celebrating? And trying to keep it simple, because really the tool is a document that enables us to reflect on what we're doing. And it's about how we approach that. So it's a state of mind. It's not going into the process looking for a way to justify what we do or to keep things as they are, to maintain the status quo. It's going in with that thinking about how can we do better. The framework should prompt a conversation. So we're trying this during its development. We tried it in local places. We've tested it out with other services, and through our self-assessment, we'll be looking at ways that we can do things differently. The framework also amplifies some good practice. So within the document, there are examples of how people have done things that we can draw on and learn from. What it also does is put in one place all of that practice that we all talk about, and it's all in one place. So things like anti-oppressive practice, trauma-informed, asset-based, restorative, all of those practice bases are in one place within the document, so people can link into those and have a look at what fits with their organisation. So we're asking people really to do something quite simple, and it's doing something at a time when you're not under masses of pressure, when it isn't about how do we meet this deadline, but to create some time for some reflection, which I know is easier said than done, but this is a tool for that. And it's very simple. It's thinking about what you do now, either as a whole service, as a whole organisation, or for a specific project. And we've got people doing this in all different ways. But I've done it with my whole team, looking at our service, but we're also testing it on a couple of smaller projects. So looking at what we do, how do we measure it? How do we know we're doing it well? How well are we aligned to this? We're scoring ourselves. How confident are we that we do some of this? And if we were doing it again, how could we do it better? And that's where some of the case studies and some of the practice-based links give you some opportunity to think about, are there different ways we could be working, different ways we could really get alongside communities? What we also have is some support in place. We're hoping as people start to use the self-assessment tool that there will be people within organisations that can help each other, that kind of peer support model. For the moment, there's a small group of us that have been using it, and also one of my teams that will support the rollout. But I think that will grow as more people start to use it. As a result, of the self-assessment, obviously we're hoping that there are changes, that things can be improved, and as I say, I've done it on a couple of my services. We've been looking at it in how we use the approaches for tackling violence in neighbourhoods. It's a piece of work we're on with at the moment. So we're very much working alongside people within the community to develop our response to violence. So we're not producing a plan and taking it out for consultation. We are writing it with them. We were looking at all our different roles within that. We're looking at what's good in that community rather than starting with the problems. And we're also looking at, are we reaching the right people? And we're working really closely with our ward councillors on that and trying to make sure we hear a whole range of voices. So that's given us a slightly different approach to how we're working on that project. And some of you will have been involved or know about the Community Champion programme during COVID. That very much informed this approach. So that was about, again, hearing the right voices, hearing different voices, recognising that different people can play different roles in building trust and hold trust in different parts of communities, and how do we work alongside that. And then celebrating when good things happen, when good things work. You know, quite often we're working on projects that have really challenging outcomes and can take a really long time to see a difference. So we've tried to build in kind of shorter term opportunities to focus in on some of the successes and make sure we share those successes with the people involved in the projects. So it doesn't have to be large, you know, massive changes, but it is about tweaking what we do and thinking about projects that we've done, that you've done, that others have done, and what can we learn from that and how can we integrate it into our work going forward. So I think the ask is, as representatives on the board, back in your own organisations, is this something that you could initiate? Is there a way of using this in your organisation? Could you be one of our early adopters? And just ending with a quote from Lisa Cherry, who I'm glad I called her Lisa. People of a certain age like me will remember Nina Cherry, and I keep calling her Nina Cherry, Lisa Cherry. So she's an academic and researcher who is looking at belonging as an intervention. She's particularly working around young people in care. But she's got some really interesting research on her website around belonging and the impact of belonging. And we've been drawing on some of her work as well. And, you know, with the vision of supporting and enhancing relationship-focused practice, together we can create schools, services and systems that do not add to harm, but rather build connection, safety and belonging. And I would really recommend having a look at some of her work if you're interested in that angle around belonging. So that's where we are. We're rolling it out now. It's been adopted by our organisation at full council. So we've got a plan on how we're going to spread it through our organisation, and it won't be we do it this way today and it'll be all ICF tomorrow. It will be incremental. It will grow and spread, and it'll probably tweak as we go along, as we learn. And and then we'll review it in 12 months and see what difference it's made, to see if it's making the impacts that we hope it will, that we're working more effectively alongside communities. We've got some measures. It's not an easy thing to measure, but we have got some that will give us an indication. But we also think the action plans that will come out of the self-evaluation at a much more micro level will help us understand through stories and experiences whether it's making the difference that we hope it is. So that's my final slide.
Thank you very much, Jo. I already have a hand up, and it's from Carol McKenna with a question, I assume. Carol, over to you.
Comment more than anything. Thank you, Jo, for that. Like I say, we've heard in the Health and Care Partnership, we've had Jill particularly come and present in quite a few of our meetings, and yourself, so it's really helpful to hear it again here. I think what I would say is we are really hoping that we'll be able to take a discussion in one of our other meetings to see what's the best way of taking this forward, really, and sort of disseminating it and using it within our partners. And we felt probably the best route is to take it in through the ICB committee with the recommendation that people endorse the approach, and the partners in the ICB committee take it away and think about how they best use it within their organisations as well, alongside the other approaches that they have to working with communities. It's not intended to replace a lot of the good work that goes on, but it's intended to complement and supplement it. So I think, Jo, if it's all right, we'll be in touch outside this meeting with a view to scheduling that in at some point early in the new year, if that's okay.
Yeah, that'd be great. Thank you.
Okay.
Excellent. Can I just re-emphasise something Jo said, that this was for any organisation to look at and use. So, Jo, how if an organisation say, no, we'd like to explore this further or take this on, what should they do? How do they get hold of the documents, or should they speak to you? What should they do?
I think in the first instance, make contact with myself. It's probably the easiest. And we are building a kind of small team of people that will be able to come out. Me and others are happy to come out and give a presentation, to run through the document, to run through the self-assessment. And then it really depends what help people want. People might want to go away and just do it themselves and then come back if they need some signposting or some support around something particular. But I think in the first instance, it's just get in touch for a conversation, and because it might be slightly different for different people.
Indeed. So we'll make sure that that's identified very clearly in the minutes, so that people know how to get hold of you as such. I suppose the interesting thing will be the feedback, and for organisations to come back with examples and so on, which would be a benefit. I have a queue of hands now, and I'm just trying to... Alistair was first, I think, then Christine Fox, then Councillor Carol Patterson. Alistair, over to you.
Thanks, Councillor Kendrick. Thanks very much for that, Jo. That was a really useful and interesting presentation. I think I might have heard bits of it before at the Youth Development Programme Board as well, and I just really wanted to highlight, that kind of link across to youth services, leisure services. I am a little bit biased, and also Kirklees Youth Alliance as well, and the role that the VCS can play within this. It would be great to get you to a Kirklees Youth Alliance network meeting if we can, and have a bit more further discussion there, because I think that mental and physical health and well-being impact, that if we get this right, if we do a preventative side, I think that can be really useful in the context of this board as well. So really useful piece of work, and I hope we can take it forward with you.
Thank you. I'd really welcome that.
Lovely. Christine Fox.
Yes, thank you. Thanks, Jo. That was really interesting to hear about the framework, and it really resonates with me as a director of a local housing provider. A lot of the work that we're trying to do, working alongside communities, so there's a lot of synergy there with what you're trying to do within the council. So certainly we'd like to look at the toolkit. It looks great. It looks like it'd be really useful. So more than happy to kind of take that away and use that in our work, and share anything that comes out of that with you, if that would be helpful. So thanks for that.
Thank you. Yeah, it would be great to start getting feedback when people start using it, because that'll help us learn.
Excellent. Councillor Carol Patterson.
Sorry, thank you, Viv. Excuse me. Yeah, I chair the communities, the Community Partnership Board, which is the board that started all this off, and it's really good to now see how all partners, not just the partners that are represented on the communities board, but everybody that works within the community is taking this framework on board. It will do so much more. I mean, the synergy that can come from everybody working in this way, as opposed to a small team. What we had perhaps was a small team of people going in and trying, well, to do something to a community, to bring it together, as opposed to working with the community and other partners working in the community to not provide that cohesion, but to make sure that, as the framework says, that everyone does feel inclusive. So I'm really pleased to see how it's been received here today, and can only sort of say, great, thanks. Let us hear how successful you've been in the future. I'm sure you will be, but just love to have your feedback in terms of your experience of using the framework. It is, as I say, it's really good to hear what people have had to say today. So thank you.
Excellent. Thank you very much for that, Carol. Catherine Riley.
Thanks, Councillor Kendrick. So thanks, Joe. It's a really interesting presentation, and we welcome it from Calderdale and Huddersfield Foundation Trust. And I think we've got a lot to learn from you about how to engage with communities. So we look forward to using the tool. I look forward to the conversation that Carol has at the ICB committee, because obviously we'll integrate with the rest of health on it. And look at a way that we integrate it into the evaluation that we already do. So it, rather than being something that we layer on top of and create a new task of, we integrate it into the evaluation work we're doing, because that's the way that we'll make sure that we use it on a regular basis. But thank you very much for your presentation. Really interesting, and we will follow up.
Thank you very much for that. I don't think I'm seeing any new hands. Carol, is that your old hand? Carol Pattison, is it? Obviously is, by the look of your expression. Well, Joe, thank you so much for that presentation. It sounds like you and your team may be quite busy in the near future. But
well, I do hope so.
Yeah, I think that has to be welcomed. We will make sure it's identified in the minutes very clearly about how people to get in touch with in the first instance if they want to follow this further. But it is a message for everyone to take back to their organisations to consider looking at this in the future, as well as those people who've already spoken about their interests. So thank you very much, Joe. Thank you.
Thank you. Thanks for inviting me.
Cheers. So, colleagues, if I could ask you to move then to item 8, which is the Kirklees Health and Wellbeing Strategy Implementation Plan. And we have Emily Parry-Harris here and Phil Longworth and Stacey Appleyard, who are listed as contacts on my agenda for this. And I assume, Emily, you're going to start this off.
I am, yes. Thank you very much, Councillor Kendrick. Yeah, I've brought some friends with me, Stacey and Phil, as you've mentioned, but Alex Chaplin and Joe Hilton-Jones are with me as well, because actually it's Alex and Joe who've done a great deal of the legwork on this health and wellbeing strategy. So it feels right that it's them that come and talk to you. So I'm going to do a brief introduction. I do have one of the slides that's mine to deliver as well, so I'm going to come in for slide 7. But apart from that, Alex and Joe are going to take us through the majority of the slides. Alex is going to share her screen. Just a few things then I wanted to say by way of introduction. What we really want to focus on today is the role for the Health and Wellbeing Board of making the health and wellbeing strategy into a thing that is being practically used. Also the role for the individuals and organisations and services that make up the Health and Wellbeing Board, and then also how we use it in our formal and informal partnerships. I just wanted to remind you of a few things. So the Health and Wellbeing strategy was approved by the Health and Wellbeing Board in September, and this presentation today is the kind of, okay, so now what do we do with it then? Or to rather to inform you about how we're going to do it, not to ask you. We know what we're going to do with it, but we want to inform you about it. I want to remind you that it is a high-level strategy, and that it's the interdependencies with the other high-level strategies as well that are really going to help us bring this to life and make it a thing that is practically applied. And you will have noted in the paper that accompanied the agenda for this meeting that there's a timetable for when each of those individual strategies is going to come in front of the Health and Wellbeing Board as well, so you can start to kind of join the dots up. We really want you to take note of it today and think about how you're going to use it, and for the health and wellbeing strategy really to become part and parcel of how we do stuff round here. And it's really timely that we come directly after the Inclusive Communities Framework, because actually these two things together form a really important part of our vision and values. So I'm going to pass over now to Alex, Stacey and Joe, and then I'm going to do my little bit. The other thing that I wanted to very, very quickly acknowledge, and I'm going to embarrass Phil horribly by doing this, is I want to specifically thank Phil for the work that he's done specifically on this health and wellbeing strategy, but also more generally and more broadly, and just to thank him for being a brilliant colleague on this, which I think will be his last health and wellbeing board.
You're stealing my thunder.
Oh, I'm very sorry, Councillor. Well, you can do it again at the end. We'll embarrass him twice. We'll embarrass him twice. But I couldn't let this pass, given the amount of work that Phil has done on the health and wellbeing strategy without acknowledging that. But I will stop now before I steal your thunder any further. I'm sorry. Alex.
Yeah. Okay, so this slide here is just speaking to some of the things that we're going to be covering shortly. So we've got delivery, the check and challenge indicator framework is just a bit more of a visual representation of what we've got on the previous slide, and you should hopefully have seen this in the previous meeting where we signed off the strategy. So when it comes to delivery of the cause, as we're calling it now, it's not JAWS anymore. So we recognise that the delivery of the strategy will be through mainly the action on the priorities that we've set out there. So we've got mental wellbeing. So it's delivered through the Kirklees all-age mental health strategy and overseen by the Mental Health Alliance. We've got healthy places, which will be arrangements for oversight of this priorities. They're kind of still being developed. We'll hopefully have some updates on that soon. And then the connected care and support be delivered through the emerging Kirklees Health and Care Plan and overseen through the Kirklees Health and Care Partnership. We also outlined that, people who live, work and study in Kirklees, there will be some work going on there around raising awareness for people about, how to take ownership of their own health and wellbeing, but we'll talk more to that when we get to the raising awareness section. And also, the delivery of key strategies and plans. So I believe we must have spoken about before about the top tier strategies that we are developing in Kirklees. So this health and wellbeing strategy sits alongside the ICF that you've just heard about, the environment strategy and the inclusive economy strategy. And we've just got an outline here about so just some examples of the various strategies and plans that will sit alongside all of those top tier strategies, and also some of the places where they'll sit, within the ICS. And things like that. Plus, there will also be obviously individual organisational plans and things like that, but that will be down to organisations to develop themselves. So I'm just going to pass over to Stacey.
Hey everybody. So at the moment we're pulling together a communications plan to raise awareness of the work that's been done on the strategy. And what we hope to achieve is to bring develop a suite of resources and toolkits for partners and stakeholders to share and to spread the word even further. And just some of the things that we're wanting to produce are a plain English infographic that's specifically to go to the patients that we spoke to. So around 12 months ago now, we went out and spoke to people about what their future health and wellbeing aspirations were. So actually it's about closing that feedback loop with those people that we spoke to. And I think we spoke to about 6,000 people in Kirklees who live, work and study. So it's about going back to those people and saying, this is what happened when you spoke to us about your future health and wellbeing aspirations. This is where it's gone and this is what the plan is in the future to help us achieve that. There's a couple of other different ideas in terms of how we can also raise awareness in terms of an interactive content website where people can, either that be stakeholders, partners, or the public, who can use that interactive website to highlight how they can use some of that in action. So some of the I statements and some of the priorities and things like that. We'll be producing a locality version of the strategy that connects local activity and plans, and there'll also be a self-assessment tool, very much like the framework that we've just seen, to support organisations identify how they can implement the health and wellbeing strategy locally.
Okay, I'm just going to pass over back to Emily now to talk about the Indicate framework.
Thank you. So we're going to do all of that, but then how are we going to know that it's made any difference? How are we going to notice that it's made any difference? You'll remember that we've talked previously here about the shared outcomes, and they're a really key element of the strategy. But what we've also tried to do in refreshing the health and wellbeing strategy is make it clear where the other top tier strategies pick up particular emphasis on the outcomes. That's not to say that they're not all important to all of the strategies, but there will be some in different strategies that are more important than others. Recognising that what we're trying to do is create a network of those outcomes working together. We're also working to refresh the basket of headline indicators. We've had those in place for a long time, and what they generally do is they indicate that we are going in the right direction, that the work we are doing is making the difference that we want it to make, and that in an accumulative fashion, it's having impact on the health and wellbeing of the population of Kirklees. We really want to refresh those indicators, and particularly to help our understanding of inequalities in Kirklees. So are we making the biggest differences in the communities we want to make the biggest differences in? And that's really at the heart of what we're doing and why we are refreshing these indicators. We've also talked about each of the priorities having identified a range of success indicators, and they will form part of a toolkit really that can help people understand the difference that they are making. That's me. Back to you, Alex.
Okay, so communities and together as partners from various organisations. So we've got a set of clear values and the ways of working, which, as I said, are on the screen now. So the culture change will be, as we see it, as important as the focus on the priorities and the factors and all the things that we've mentioned already. And they do sort of require a consistent effort over the lifetime of this strategy, so over the next 5 years, to embed them. So we'll be working with relevant colleagues across the systems to sort of understand the current learning and organisational development offer and the work on implementing other key strategies and plans we see can support this aspect of implementation. I think as well that will kind of link to to individual plans, as we've said before, for organisations, and making sure we've got those sort of open lines of communication with other organisations as well. Now I'm going to pass to Jo, I believe. Yes.
Lovely, thank you. Yes, so in terms of check and challenge, this is the process that provides assurance for the board that the partnership and our partners who are responsible for delivering the Kirklees Health and Wellbeing strategy are delivering on what is set out within it, and delivering in terms of making tackling inequalities. So there are it sets out the aspects for delivering against, so including the vision, the values, the ways of working, and so on, and very clearly in terms of the three cause priorities, and are we addressing and considering those 6 factors that impact on our health and wellbeing, both positively and negatively. And then it's very clearly in terms of the arenas that it's been delivering in. So that's our individual organisations, our services, in our formal and informal partnerships, and in our statutory governance structures. So as part of this, some of the tools and the measures for doing this have already been covered, but we're developing an implementation self-assessment tool, which is a process of being able to check, are we considering it in our strategies, our service plans, our team plans, and so on. And then we've also got the I statements that we've got a slide on just after this, and those really cover what good looks like for people in Kirklees who live, work, or study here. And the really positive thing about that is already Healthwatch Kirklees that produce these have been pretty much inundated with calls from people saying, what can you produce as I statements that are most relevant to our services, our teams, talking about how they can use them, and as part of their assurance that they're delivering what people in Kirklees want and would benefit from and would make a difference to them, and as part of their assurance that they are making that difference. So yes, I think that covers the check and challenge process. We have a timetable that has been set out in the paper that you've received today. So in terms of that, there's the timetable for the health and wellbeing meetings coming forward, and we've got the top tier strategies that we are considering in relation to the interrelationship between the cause and our other top tier strategies. And obviously we've had the inclusive communities framework today. And then we've got a schedule of the 3 priorities and when they are planned to come to the Health and Wellbeing Board. So there is an opportunity for to gain assurance in terms of progress being made and what's being tackled and prioritised under those 3 priorities. And there we've got some of the I statements. So Emily, is this where you come in?
It is, yes. So thank you, Jo. I did feel like I might ask Phil to do this as his swan song, but then I hadn't asked him to in advance, so it doesn't feel fair to drop him in it quite now. But just to remind the board of the recommendations that were in the paper, we asked you to comment on and support the proposed approach to implementing the cause. And we asked you to consider how board members can support the different elements of the cause implementation plan. I think a really important thing you can do is use it and talk about it and make regular reference to it. But yeah, that's the end of the presentation. Thank you, Councillor Kendrick.
Thank you very much, Jo, Alex and Emily. I was just going to refer board members to the last page of their agenda pack because that's where those recommendations sit. But I've already got some hands coming up, so I'll pick up on those, and I'm just looking for who I saw first, who's now disappeared out of it. Liz Meir was first, then Alistair, and then Carol McKenna for a start.
Thanks, Councillor Kendrick, and thanks for an excellent presentation. I think it really sort of summarised in a very succinct way about what the strategy was about and how we can support that. So I chair the Kirklees Integrated Care Place Committee, working alongside Carol and Emily, and we have the strategy that we came to the committee, fully supported it. We were really pleased to see in it the reference to digital where appropriate for people, and to think about how as organisations we could support that, because if we can wrap our sort of digital data about care and health around people, we can really support them so they don't fall between the cracks when they move between organisations. So I think that's one of the things we thought was really important for us to concentrate on. And also looking at the I statements, there was one on end of life as well as starting well, living well, and we thought that was quite important. People have changed the place that they die in. More people now want to die at home. So this sort of continuum right through a person's life to having a good end in life, we thought was something we could work on together, as well as lots of other things in the strategy, but they were specifically raised as things that we thought the strategy supported, and the I statements were supporting as well.
Thank you very much, Liz. Alistair.
Aye, yeah, thanks very much, guys, for that feedback and that overview. It's good to see it's moving forward from the strategy being approved. I think we're already in this awareness stage, aren't we, as well? So you'll be pleased to know it's gone to Kirklees Active Leisures Board. I think Stacey's coming along to Third Sector Leader Board as well. So spreading the word is definitely important. As I said at the last Health and Wellbeing Board, I'm still cautious about the inequalities impact. I really am worried about that, given the economic situation we're in. I think it gets harder every day to try and close that gap instead of it getting bigger. So, and I think that's something we've really got to keep an eye on with this one. And I just wondered, it's really good to have the priorities one coming back to each report and a deep dive. I think that's excellent, but can we also have an update on the other priorities, even if it's just a summary one, because I wouldn't like to wait a year until we get the Healthy Places one. So it'd be really good to have a brief update of all of the priorities and work being made there and progress being made. If we can have a deep dive on one at a time, then I think that would be excellent. But thanks very much. It's the hard work starts here, isn't it, really now with the strategy? But thanks very much for that today.
It absolutely is, Alistair, and I think doing all of this through the inequalities lens is absolutely vital, because, yeah, as you say, it's getting harder every day.
Yeah, the inequalities thing is the thing that bothers me. I mean, for people, and we often use the term poverty, which is a very emotive thing, but, you know, financial challenges for people who have been struggling with that all along are likely in this cost of living crisis to be pushed further down. But then we have another cohort, if you could say, of people who will start to fall into that. The financial challenges they face will be greater than ever before, perhaps, and the impact on their health and their family's health is going to be a challenge. But I think it's a very good point, Alistair, about us not forgetting the other things and perhaps building that into future agenda items so that can come back to the board, and I think that would be quite important. But good news about spreading the word, Alistair. Well done. Carol McKenna.
Thank you. Thanks for that, Emily and colleagues. This is going to look like we've rehearsed it after what I said about the inclusive communities and how that was coming through into the Health and Care Partnership, but we haven't really. But I know it's because of the dialogue that's going on outside. We've recognised in the last couple of meetings we've had in the Health and Care Partnership Committee that Liz chairs about the importance of developing this work, and in particular going back and having another look at the indicators that support the outcomes that we will particularly be responsible for, you know, delivering. So we've got a development session planned on that in mid-December, which is really good and really timely, I think, considering this conversation. I'm not sure if it's a question to Emily, but I'm really pleased to see that we've got discussion scheduled in for, is it February and March, with the other strategies, you know, around the environment and the inclusive economy strategy. Is there similar work underway to understand what are the indicators that sit underneath those high level strategies to indicate progress on the outcomes that are connected to them? It might just be that I'm just not cited.
Yes, there is. If you remember, we had a table that we used in the Health and Wellbeing Board previously that had all of the, well, at that point it was the 7 Kirklees outcomes, wasn't it? We've now got the 8. There was the 7 Kirklees outcomes were down the left hand side, and then you had the high level indicators that indicate that we're going in the right direction, and then we had some specific things that we could count that would tell us, and then some very, very specific service. So we're refreshing that whole table. We will, in principle, we will be most interested in the best start in life and people as well as possible for as long as possible in the Health and Wellbeing Board. We will also be interested in the clean and green and safe cohesive communities ones as well, but they will be spread out across those top tier strategies, and then we will hold all of those indicators together in a single overarching framework, and periodically we'll look at all of them all together so that we can understand the whole of the jigsaw, not just the corner pieces.
Lovely, thank you.
Okay, thank you very much. I'm not seeing any more hands for any more comments as such. I'd just make a comment about how impressive the 6,000 contacts that you talked about, Stacey, was, you know, is quite something, is that, you know, and getting back to them and saying, giving some feedback will be a challenge, but I'm sure you're up for it. Can I just, sorry,
I just want to specifically say that those 6,000 contacts that were made as well, they were 6,000 different contacts. You know, usually if you send a survey out, you get lots of responses from people who look and sound quite like me. That's not what we got in these responses. We reached communities we wouldn't have otherwise done.
Yeah, but very well done for that. It is impressive and has to be celebrated as such. I think from what's been said, some of the conversations that go on outside the board and the links between different boards and partnerships actually shows a huge strength in moving this forward, you know, and I think that has to be acknowledged and celebrated. Can I thank you, Stacey and Joe, Alex and Emily for bringing this to the board, and we'll look forward to continuing down the route with this one. Thank you very much.
Very welcome. Thank you for having us.
Thank you. My pleasure. Could you wear many more clothes, Emily? I mean, you look like you're outside.
I'm not going to comment on that, Councillor Kendrick, if that's all right, but possibly not, no.
So if we could move us on then, please, to item 9, future commissioning arrangements for community pharmacy, optometry and dental services. And Carol McKenna, I think you're going to help us with this.
Well, up to a point, Chair, up to a point, I think might be the best way of saying that. I think when I was asked to do a little update on this for this agenda, I was asked to do an update on where we are with the process around the changes in the commissioning arrangements. So I'll do that in a second. I suppose what I would just like to say before is, by focusing on the process around the changes in commissioning, I don't want to in any way, don't know what the right word is, not give full attention to the scale of the challenge that we know exists about access to dental services. And I wanted to acknowledge that up front, and I suppose also acknowledge that in the update I'm going to give you, it might feel a bit process driven. It's not designed to provide answers to some of those challenges, but I'm sure we will discuss them, and obviously really happy to hear those comments. But just a little bit of sort of managing sort of the expectation around the nature of the conversation. So, as colleagues will be aware, dental services have been commissioned by NHS England since 2013. Previous to that, they were commissioned by primary care trusts. And then when CCGs were established, that responsibility transferred to NHS England, and that has been the case ever since. So it's been some 9 years, or over 9 years really, since we commissioned these services locally within Kirklees. However, the establishment of integrated care boards under the Health and Care Act of earlier this year obviously has changed things a little bit. As part of that, there was the expectation that service commissioning for dental pharmacy, community pharmacy and optometry would be delegated from NHS England into integrated care boards. As some colleagues will know, the commissioning of general medical services, so your general practice services, that was delegated from NHS England into CCG some years ago, and that arrangement continued into the ICB, but it was not the case for the other 3 independent contractors, and that is what is now being changed. So the delegation of what are called POD services, if I can just use that language for short, you know, pharmacy, optometrists and dentists, the delegation of POD services is included within the scope of delegation from NHS England to ICBs. And there's been some flexibility around when ICBs would take this on. So it is the intention for the West Yorkshire ICB to assume delegation for POD services on the 1st of April 2023. So that's some 4 and a bit months from now. And the delegation of community pharmacy services includes responsibility for GP dispensing services, and dental includes primary, secondary and urgent dental services. So in order to manage this process and get us prepared for the 1st of April, there's been a sort of, as with all things of this nature, there's been an assessment process undertaken. So the ICB has been required, working with its places, to pull together an assessment of where we currently are and complete that assessment framework for, you know, consideration by NHS England as to our readiness to take on the delegation. This is known as the pre-delegation assessment framework, and that was submitted to NHS England at the end of September. It covers a range of areas, including quality and transformation, governance and leadership, finance and capability and capacity, and that was all completed and submitted in accordance with the timescales. So the NHS England Moderation Panel met in October, and West Yorkshire have been approved to take on responsibility for the delegation of these services from the 1st of April next year. That's subject to the final decision by the NHS England board on the 1st of December, but the recommendation that will be going to that board will be that West Yorkshire can take on this delegation. I think it's worth saying that there are some risks that have been identified. So I think what I've described to you really feels like quite a one-way process, with us having to demonstrate to NHS England at West Yorkshire level our ability to take on delegation. However, there have been 3 particular risks that have been highlighted as part of this process from the ICB into NHS England, and I just think it might be worth me mentioning them because they were reported to the ICB board last week. So in particular, the risks that were highlighted as a result of the assessment process were in 3 areas really. So first of all, there was the need for some assurance around the full transfer of workforce capacity from NHS England. So those people who are currently working on this with NHS England, we need to have a resource transferred to West Yorkshire and other ICBs to support that delivery. Also seeking assurance that there's sufficient funding to commission the service to a satisfactory standard. And the third one was around a full understanding of the service issues that we will be taking on under delegation, and a commitment from NHS England to work together to manage to best effect any future contractual flexibilities that will support addressing those issues, and particularly with dental services, because we know of that issue. Those have been highlighted by not just us as an ICB, but other ICBs as well. And I think it's important that that has been done, because particularly dental is such a challenged area. If you were to ask me here today, do I think all of those conditions will be met to our satisfaction? Do I think we will ever be happy that we have enough money to do everything that we'd like to do? Clearly, that's not something that I could ever say with any confidence, given the current situation and the scale of the challenge. But it feels very important for ICBs to have made those statements as part of this process. So, as I say, some key risks identified from an ICB perspective as we've gone through this. And then obviously, as you know, we have identified a number of service issues and priorities as well. So I won't rehearse it here. Stacey has spoken to us about this before, and no surprise to anyone, there are national and local issues in relation to access to NHS dental services, and Health Watch reports both into Kirklees and West Yorkshire have highlighted those very strongly. So the sort of things that we are seeing, some of the challenges are similar to those across the health and care sector, such as workforce pressures due to the retention issues and recruitment issues for NHS dentistry. But also some challenges that result from the nature of the national dental contract, which has been in place for some considerable time now, but which is now regarded as not necessarily helping in terms of being able to address some of those challenges. And there's been recently, some slight changes made to that, but the challenge remains there. And obviously, as with everything else, this has all been exacerbated by the management of COVID recovery and tackling backlogs as well. So I don't think I'll go over that anymore, because I'm sure we'll get into that in the conversation. But in terms of the process that was asked to update on, we are on track at West Yorkshire ICB to take on responsibility for commissioning those services from the 1st of April. And the intention behind that is that by bringing it a bit closer to our populations, that should put us in a better place to be able to identify solutions at both place and locality level than might be the case when it's commissioned at regional level. So we should be able to maximise any opportunities through our approach to working in neighbourhoods and in places. But I think might leave it there really, if that's okay for now, and happy just to take any questions, which I'll answer to the best of my ability. And I'm just saying it a little bit of a health warning, because I'm not an expert on the dental contract, not having been close to it for a few years, but very happy to hear views to make sure we can feed them into this process.
Thank you very much, Carol. I'm not seeing any hands up at the moment. And we have one straight away. Councillor Jackie Ramsey.
Carol, I don't know that I know enough about the dental contract either. I'm going to gen up about it, but I do understand that different practices get paid different rates, different tariffs, don't they, for the UDAs? When it comes to be a more local contracting arrangement, would you have the ability to standardise that so that because my understanding from dentists that I've spoken to is some dental practices really find it very, very difficult to make ends meet on the tariffs that they're on, whereas others are clearly potentially making a profit on the tariffs that they're on, but it's just one system. So I'm just trying to get my head around that and see whether or not you would have the power to make that a little bit more equal, or even to if you're talking about inequality, even to actually promote a higher tariff in those areas where we know we've got more oral hygiene, oral issues.
Yeah, it's a good question. My understanding, and like I say, I may get this wrong, but my understanding is the units of dental activity is the way in which dental work is paid for, and there's 3 categories of that when you go to the dentist. The third being for the more complex, and my understanding is that is the same rate that is paid for irrespective of which dental practice you go to. However, what it doesn't account for is the fact that there's a different level of complexity in patients across different practices. So the way I've heard it described by some dentists is you don't get any more doing, I don't know, 6 fillings than 1 or whatever it is. And I don't quite understand exactly how that operates, but I think it's often due to the fact that some practices, particularly in areas where there's high levels of oral health need and deprivation, find that the amount of time and, dental capacity that's required to support particular individuals isn't properly rewarded through the nature of the contract. That's where the inflexibility is. I think it's a really good question about whether we'd have any local flexibility to do that, and I would need to understand a little bit more about whether there is scope within the dental contract for things like local enhanced services in the same way that there is with general medical services. That would be something I think we need to understand a bit more about as we take this on.
Thank you, Carol. Well, I'll ask more questions of dentists and I'll come back if I find out.
Please, yeah, so will I.
Excellent. Stacey, you wanted to speak.
Yeah, it was just coming on Councillor Ramsey's point actually in terms of the UDA levels. So there isn't different prices for UDAs. The level of UDAs across Kirklees, for example, are very different, and that is set on a historical value. So you'll find that you have lots of dentists in affluent areas and they have a lot of UDAs allocated to them, whereas some in more deprived areas don't have as many UDAs. And I think it would be interesting to try and level some of that out, particularly when we're talking about health inequalities. It was just to confirm around that is set by historical values through the dental contract, and that's never been able to be changed. I don't know if that will change if once it comes across, but it was just to confirm on that point. It's not different levels of value, it's different levels of numbers of UDAs.
Thanks.
That I understand.
No, that's much clearer than I was. Thank you.
Thank you both. I will go back to the dentist who was informing me about the different rates, so I'll come back.
Fine, that's fine. Thank you, Emily.
Just to add a further little bit that I think I understand about UDAs is that there is a total amount of UDAs that are able to be used across the whole system. So if we are going to issue more UDAs to either a new dentist or to a dentist in an area of more significant need or higher deprivation, we have to wait for a dentist in another area to give their contract back.
Oh.
So it's a complex system, the UDAs, and it's one of those things that when somebody sits me down and explains it to me, you can kind of make it make sense. But we can't just they won't just, or they can't just create additional UDA capacity. You've got to wait for somebody to, I don't know, hand that little mirror back and not be a dentist anymore.
Thank you for that, Emily. Is that an old hand, Stacey, or you wanted to speak again on that? No. Thank you very much for that. I think that's interesting, and I think the dentistry aspect of this is one of the most challenging, and we know it's been a challenge not only in our area but everywhere across Britain. I think as much as anything, I think it's very wise to ask about staffing levels and resources, and also what the issues are, and I think you'll learn more and more about the issues as they go along. I just wonder at the point where ICBs have taken on these roles next April across the country, if almost it's a stronger voice with lots of ICBs probably saying similar things, particularly around dentistry, that might put some pressure on for change. I can only hope that anyway. I've not seen any further comments on that, so thank you very much for that, Carol. If I could move us then on to item 10, please, which I was really happy to see Richard Parry pop up. I knew he was going to be late and he got conflicting meetings. I was thinking, oh, I wonder what we do if he doesn't arrive, but there we are. Here he is. And item 10 is adult social care reforms. It's a presentation on adult social care reforms and the implementation in Kirklees. So I think we're all very interested in this. So over to you, Richard.
Thank you, Chair. Although I'm going to dodge this because actually I've had to go to a 3 o'clock meeting. So my colleague Alexia, who is on the call, reassuringly, is going to talk us through this.
Before.
No, she's definitely here. I have double checked before I kind of absented myself.
Thank you, Richard. Thank you, Chair. Good afternoon, everybody. As Richard said, my name's Alexia Gray and I'm Head of Quality, Standards and Safeguarding Partnerships within Adults. So we wanted to update you on social care reform, but since this was put on the agenda, there's been a little bit of movement with that, with the statement from the Chancellor. So I'm just going to talk through some of that and the implications and then the work streams that we do need to continue with. So I've just put a bit of a presentation together, which I'm more than happy to share afterwards if you'd like it circulating with the minutes.
Yes, please.
So bring that up. Has that come through okay?
It has.
Brilliant. Okay, so as I said, I'm just going to touch on the key elements of reform and the context in a wider programme of change. Just give you a little bit of an update on the fair cost of care exercise, more of a focus on CQC for reasons that I'll explain, and then some summary of key work and next steps that we've got planned. So just a reminder really that the reform came about, which it was built on existing social care legislation such as the Care Act, and then it was policy intent that was split between two further white papers, and it put a much greater emphasis on personalisation, housing, carers, etc. But I think it's important to say that we were already doing a lot of that anyway. It was just that it was built into the Health and Care Act. A big element of that was around CQC gaining inspection responsibility for local authorities in the same way that Ofsted does, and I'll touch on that a bit later on. There was significant reform in the way that which people pay for their care. Lots of other pieces of reform that were due to be published or have been since around mental capacity and mental health, and it all sits around increased demand generally, changes obviously in the NHS arrangements and other operational pressures, and there were serious concerns about the capacity that would be needed to address all that. So the Act or the bill received assent on the 28th of April. I won't go through all this, but the four key components are the bullets at the bottom. So it was introducing a cap on the amount that any individual could spend on their personal care, and that was around the £86,000 mark. A more generous system of means testing, fair cost of care, which I'll touch on, and enactment of 18.3, which would mean that all individuals could ask the local authority to arrange for their care. So there would have been implications around the numbers of people coming forward and the increased number of assessments that would be needed to be able to respond to that, both financial and Care Act assessments. And also from a local authority point of view, the difference in introducing that cap and the subsidy that the local authority would need to provide. But as I said, it's a much wider programme of change. So I've just put this slide up because a consultancy company called Newton's had sort of mapped it over a longer period. So the recovery period was obviously around the workforce recovery, the backlogs, the NHS recovery from the pandemic. Much of that we're still seeing is ongoing. The reform bit sort of came into the middle of that. So there's charging reform, but then there are other things around assurance. There'll be liberty protection, safeguarding coming in from next year, and then the integration white paper, and all of that was designed to bring a sort of a bigger transformation programme around systems and technology, new operating models and workforce development to leaders to be able to transfer to new models of care. So the reform was seen as quite an intrinsic bit of that, but not the only bit of that. And then what they did then was to split those priorities into short, medium and long term. And the reason that the medium term was by October 23 is because that was when the charging elements of reform were due to come in. So the short term, again, I don't intend to go through this line by line, but things like the fair cost of care, recruitment and workforce strategy, IT, and then going back to the previous slide, moving into that long term around prevention strategy and the new models of care, trusted assessor models and things like that. So a much bigger change programme, not just around the social care reform. In response to that, we'd established a social care reform oversight group with various work streams to be able to look at these elements. But with the Chancellor's announcement, they've now said that the charging elements of reform will be delayed by up to 2 years, so that will take it into 2025. So instead of the bits that I've touched on around the self-funders, around the cap coming in, whereas that should have been next year, that won't be any earlier than 25. So it does leave us in a bit of a dilemma because there is a lot of planning that's needed around that aspect of it. So really by next year, we're going to be having the same discussions. We'll need to start planning for it, but we've got no guarantee what's going to happen beyond that. So it is a little bit of a sticky wicket. So what we have said is that sorry, I moved a little bit quick there, but the work streams that we'd established under the Social Care Reform Oversight Group, I think it's important to stress that just because the government have put the charging element back, there is a lot of work that is going on under those work streams that we fully intend on continuing, and we need to continue because it's the right thing to do. So an example of that being in response to the charging or the cap on care coming in, we were looking at or exploring ways of putting digital solutions in to be able to do Care Act assessments online. So at the moment, we've got a system in place, so 90% of our financial assessments are currently done online. The Care Act assessments are a little bit more complicated, but looking at ways of doing it, there is a possibility that the actual assessment could be done online, but then it's validated through a trusted assessor model or other ways of validating that. So we would have had to do that anyway. That would be the only way that we could potentially deal with the volume of self-funders coming through, but actually it's the right thing to do if we're thinking about managing demand. So there are quite a lot of aspects of the work streams that we are continuing with, irrespective of whether reform has formally been pushed back or not. The market sustainability exercise was a government programme that was aimed at, or is aimed at, local authorities preparing the market for reform and to support us to move to paying providers a fair cost of care. So it was aimed to determine what is a fair cost of care that is reflective of local circumstances, and the idea being that it would help to shape future market sustainability plans. The services that were in scope were standard and/or enhanced residential and nursing for the over 65s and domiciliary care over 18s. So it's, again, we're in the bit of an unknown situation at the moment. So the exercise has been completed within Kirklees, and that needed to be submitted on the 14th of October. The intention was that the Department of Health and Social Care would look at those submissions nationally throughout the course of November. Feedback could be provided in December, and then we would be hopefully publishing our market position statement in January. As it stands at the moment, that is still the timescales that we're working to, but whether that actually happens or not, we don't know. But again, the market position statement is something that we'd still need to do anyway. So it's not, none of this feels that it's been wasted in any way, shape or form. They've been valuable things to do. The CQC assurance framework is in the bill, and as it stands, we don't believe this. Well, it's not been put back. It's still due to come in from April next year. So that includes implementing an adult social care data framework. There's a duty for the CQC to review and assess local authority performance. New legal powers, very similar to the Ofsted regime in terms of intervening in local authorities to secure improvement if needed, and an increase in improvement funding. And I think a lot of this has come on the back of the fact that the DHSC felt that there was, in terms of the data and the frameworks around that and the transparency, was quite different within the NHS. And I think that had been seen more throughout the pandemic. So there was more of a push to try and bring that into the adults arena as well. So they've worked closely with the sector, so Local Government Association, ADAS and CQC to co-design the assessment so that they can provide clarity about what we're doing well, the constructive suggestions about improvement. There's a real emphasis on what matters to people who draw on care and support, and that the independent view of the local authority's capacity to improve, but it's not a duplicate CQC assessment of ICS as it is a standalone for adults and health. So it's built, this is still draft, but I don't think it'll deviate much from this model and the kind of draft frameworks that we've seen. So that sort of infographic just shows you that it's based on 5 key questions that are then underpinned by quality statements. So they've worked with an organisation called Think Local Act Personal. So it's built around the sort of I and we statements. There's a real block around people's experience, feedback from staff and leaders, partners, observations. And then there's also the data and the quality indicators that would support all that, as well as the best practice standard and standards and guidance. They have said that they don't want to make it overly onerous and for it to feel more like a peer type challenge event, but I think in reality it will still while they're on site and the lead up to that, it will be as demanding as it will be, I think, for the equivalent in children's. So I've put the principles up there that the CQC are working towards, so that again, that voice of lived experience is absolutely central to the development, and I think that's come through the sector as well. Building on the existing programmes that we've got, looking at transparency and democratic accountability, consistency and flexibility. Partnerships are important, and that they're very keen that all the relevant data should be available to the sector as a whole. So it's got to be flexible enough to assure the current system. The government have said that they will fully fund any costs associated with this, but we've not had any kind of figures around that yet. So the assessment will be across 4 themes, so they're set out there. So working with people, that will touch on your assessments, supporting people to live healthier, providing supports more. The second one is more around the care provision, partnerships, the community-based services. I suspect that there'll be more around early intervention in that one as well. So these are quite high level at the moment, but we have got documents to sort of break these down into a bit more detail. Ensuring safety, so that'll be around the system pathway transitions, the role of the safeguarding board, the effectiveness of safeguarding interventions, and then the last one is around leadership and workforce, so that'll bring in governance, learning, improvement, leadership, that type of thing. So where we're up to at the moment, so I touched on the fair cost of care has been submitted, so we're waiting to just hear any time now around what the DHSC are doing with that. There's a real big emphasis on CQC readiness, so we've got a work stream set up around that, but we'll be working with colleagues as well to understand what they've learned through the years around the Ofsted inspections. We've got some quite helpful documents to work from that have been produced by ADAS that are not just kind of checklists, but indications of the type of data sources that they want to look at. So we need to cross-check that with our current data sources and just make sure that we haven't got any gaps. And that's made slightly more difficult because we're in the process of bringing in a new case management system as well. So it's just complicates things a little bit, but it's not insurmountable. linked in with CQC, we haven't published a local account for a few years. We're not unique in that. A lot of local authorities haven't done one for quite a long time. But there's been an emphasis from ADAS with CQC thinking about them coming in that we really should be getting back on track with that. So the local account is where it's a public facing document and it's telling the public around what we've done around adult social care, where we think some of the pressures are, how we intend to improve on that. So we're working on that at the moment. And because we did have a peer review that was booked in October, unfortunately, the on-site visit had to be cancelled on the day because of members of the team contracting COVID. But again, what was unfortunate then is quite fortunate now, because all the work that went into the self-assessment for that has actually paved the way for a lot of the stuff that we'll need to put in the local account, and we can also factor into the CQC framework as well. I've talked about the digital options, so one example being the Care Act assessment, but there's other work going on around that and things like assistive technology. We'll obviously keep the engagement with the ICS and ICB structures, so that if there are any changes that that supersede anything that's come out of the Chancellor's statement, then obviously we'll need to keep an eye on that continuously. We're also commissioning some external support to undertake what we think will be a relatively big piece of work. So there'll be a diagnostic element to that, which we think will lead to a programme of change. So that's looking at increased volume demand anyway, and trajectories around that. So, for example, mental health being one where we've seen significant rises coming out of the pandemic. We still want them, whoever's going to come in to do the piece of work, to think about and factor in social care reform, because even if it does get delayed to 25, we've still got to model in the fact that we could have X number more people coming forward to ask the council to pay for their care. What's the financial implications of that? And then as part of that, pulling it all together, looking at where we could identify further potential efficiencies. So one area that I think we're quite keen for them to look at is reablement, when we think that area of the service is all designed around keeping people independently for longer, so delaying that need for long-term care, which is obviously at the costly end. So more around what could we do if we missed a trick with doing something that we could do that would potentially increase efficiencies. And then I think in and amongst all this, with the social care reform, there was a piece of work that started around looking at the impact assessments that the government had published in advance of that, and linking them into our own. So we still need to think about and keep the thought process around inclusion and equalities. And again, that'll be something that we'll build into that diagnostic work as well. So I think I hope that was just a useful summary of where we're at. And like I said, it was a little bit difficult, because if we'd have done the original presentation that we sort of put together a couple of weeks ago, it probably would have looked quite different. But I just wanted to sort of share some of the key areas, put the focus on CQC, because that definitely is happening, just hopefully provide some assurance that we have got things in view. So thank you.
Thank you very much for that, Alexia. Any questions or comments? Or are we all still reeling under what you're facing? James Cregan.
Thank you, Councillor Kendrick. And Alexia, thank you very much for that. It won't come as a surprise to Alexia that I'm going to jump in on the back of some of that. I'm the CEO of the Kirklees Care Association, and we represent the providers of social care in the independent sector, both in residential and community-based services. So a lot of what Alexia's just talked about is very pertinent for us, as you can imagine. But I just wanted to raise kind of some general concerns, not about not about the sector generally. That the sector has been underfunded for many years. Nationally, we know that, we're hearing it on the news constantly, which means that the sector's got a lack of ability to reinvest into its own businesses and provide better services and quality. But worse than that, it's in its current format, it's unsustainable, and we're already we've seen 8/9 care homes and services in Kirklees alone go in the last 6 to 8 months, and I think that's the tip of the iceberg. We've got rising costs. We talked about the cost of living earlier, rising fuel costs, food costs, workforce costs, nothing that we can do anything about any of that, and we have a non-increasing income, where funds just doesn't match the outgoings, which means that in real terms it's a reducing stream, and that hence why more and more providers are on the edge. And if we've discussed earlier about everything we've discussed today about strategies, etc., inequalities, all of those things, every one of those things require a sustainable and stable adult care workforce and sector, and we're on the brink of that. So I think we just need to be aware of that. And just I want to pick up one more thing, which was around earlier around, I think it was Councillor Kendrick said really pertinently that we are going to see more and more people drop into poverty. And I would say that I would absolutely concur with that. And I think that a lot of people working in adult social care, particularly at care level, will drop into poverty on the basis that we are not able to pay them a fair and reasonable fee for the job that they're doing. When you can get more money to wrap a burger in McDonald's than to look after our most vulnerable people, I think we really should be tackling that. And I think that and I think we need to look at how services are commissioned and procured by the local authority, in order to ensure that we don't keep pushing people further and further into the poverty trap. I could go on much longer, but I won't. But yeah, I mean, thank you very much. Everything you've said, Alexia, is real. But I think one of the final bit for me is that a lot of it is about let's pay a fair cost of care to providers. Well, that clearly tells us we're not doing that currently, so we need to really address it before we lose more and more people from the sector. And that's not just about independent private businesses. That's very much about the community and voluntary sector people as well, who are also being paid in an inequitable way in comparison to local authorities and the NHS. Thank you.
Thank you very much, James. Phil, you wanted to come in?
Yeah, just to build a little bit on what James has mentioned there. A couple of things. One is I'm sure everybody welcomed the fact that the living wage has been increased by 9%. It's a key component of the fair cost of care calculation. So whilst on the one hand there's been announcements about increased funding for social care, we're still working that through about what that actually means, but we think it means that the net effect will be we haven't actually got any more money. There will be more people paid slightly better, but we're talking about people who are at the absolute minimum that we can legally pay people. And that's a collective problem. And I suppose that the really good news, searching for some, is that we've now got a much more mature relationship across the health and social care system, thinking about workforce in a much more joined up way. At a West Yorkshire level, Kate Sims, who's the Director of People for the ICB, has got a particular interest in the social care workforce, and building on the work that we've done at a local level and we've done across trying to connect some of the workforce issues between the 5 local authorities. It really feels like people are coming together now. And we had a really, really useful session week last Friday, I think it was, James, wasn't it, with Health Education England, thinking about what we can do together. And there were people there from both the Acute Trust, from SWIFT, from Locala. And it felt like we were having different conversations because we really were talking about one workforce. And a key part of that was about thinking about mobility and how to encourage people to work in the system and move across the system, and how we can actually build a much more sort of consistent and equivalent, if that's the right way of putting it, set of terms and conditions. Nobody was underestimating the scale of that challenge, because it is difficult, but we've got lots of people now who are really connecting in, and a huge amount of enthusiasm to get that moving.
Thank you for that. I'm not seeing any other hands or comments. I don't know if you wanted to come back on things, Alexia.
No, I think it's just, I mean, James and I have obviously had discussions, and these types of issues are discussed in different forums as well. But I think it's based on all we can do is work at a system level around the recruitment and retention issues, because it is so true. I mean, why would you want to do a role like that when you can get a very similar role working at Lidl? You haven't got the stress and and so there is that. It's trying to get that. Making social care attractive for people to want to come and work in the sector, and to do that relies on a number of different things, doesn't it? So it's not just the terms and conditions, but it is that parity of pay as well. But it's just a constant battle, because like you said, the figures that will be announced, I'm sure, by government, because what I should have said is that they have committed that the money that they've set aside for social care reform they would still be committed to sharing that with local authorities next year, even though the reform's not coming in, but it doesn't even touch the sides. So when you see these millions of pounds, in the headlines, and it sounds, oh great, it's going to fix everything, but actually it will do very little when you think about the, like I said, the increase in the cost of minimum wage and things like that. It'll more or less, it might not even balance the books, and that's the honest truth. So it is a difficult period, but I think the one thing that we do have in Kirklees to try and respond to that is the strength of the partnerships that we've got. And that real desire to try and work together to make it as the best kind of environment for people to be in, and a safer environment for people that are most vulnerable to be looked after. So that it was just to really enforce what Phil and James have said, really.
Thank you very much for that. I'm not seeing anybody else. I do think, unless social care is really reinforced to be able to continue onwards successfully, then I think the pressures right across the system in health and the council will just be phenomenal. And I'm not sure what we can do about it. And I do understand that some people will go and work in Lidl or McDonald's or whatever because of the pay. But I think those who are committed and their heart is with social care, if pay was relatively equitable and the providers could have enough finances to pay that level of pay, those key people who we would want in social care would remain in social care and or come to social care. And it does come down to what funding is going to be available to make the system. I mean, I'm really glad there's a strong partnership making the best of what is really a crisis situation, in my view, at the moment. So I think it's something for us to watch and keep an eye on, and obviously to lobby on as well at times. Nobody else? Comments or questions? Can I thank you very much, Alexia, for being two roles, Richard Parry and yourself, and doing it so ably. So thank you very much.
Thank you.
Before we finish, colleagues, has already been touched on by Emily Parry-Harris, this is the last meeting, I believe, that Phil Longworth will be at of the Health and Wellbeing Board. And despite his boyish good looks, he tells me he is retiring. I think it's a feeble excuse on his part, but I'm
sure he didn't just mean he was shy and retiring, Councillor Kendrick.
I
It
think
could have been that.
Probably,
it might have been
that. Probably that, but no, he claims he's retiring, which is disgraceful. But I have to join you in thanking him for the tremendous amount of work he's put into Kirklees' as health and wellbeing strategy, not just this latest iteration, but goodness knows how many iterations. And also thank Phil very much for the support he's given to this board and to me personally, the information advice he's given, and across so many other groups and boards and meetings right across West Yorkshire. Who he doesn't know within the health and care system isn't worth knowing about. So if he's not known to you, you know one really. But I can only say thank you. It is really rather regrettable that this meeting of the board is virtual rather than real to be with Phil, but I'm hoping that I will and others will get the opportunity to physically meet up with Phil before he departs and goes away and does frivolous things in his own time. I'm not sure at all what he's going to do. I hope he will be busy and have a long and happy retirement. But can I say on behalf of us all, thank you so much, Phil.
Thank you, Councillor Kendrick. Richard asked me if I was going to turn up at council meetings and ask awkward questions as a member of the public, and I said no. That would be churlish of me.
It could be a good hobby, though. Some people seem to have that hobby, but there we are.
And as I put in the chat, semi-retirement. I'm not quite going out to pasture just yet, but
all right.
I'll be looking for interesting things to do in the new year, just to keep my brain ticking over. Because
I hope you will still answer my text messages of what does this acronym stand for again? Because you do sterling work in that area.
Anyway, it's been a pleasure, and Carol is now officially the last woman standing from the original Health and Wellbeing Board.
Dear, don't sound very good, but yeah, can only wish you the best. It's interesting that he's saying semi-retiring, folks, and he's looking for things to do. For those of you who have got boards and neat trustees and things, then I suspect that Phil Longworth is a key target for you all, so get to it. But thank you very much, Phil. Can I say I think that draws us to the end of this meeting, so thank you very much everyone for your attendance, but thank you very much for also those who've presented, and once again thank you very much, Phil. Goodbye.
Thank you.
Thank you everybody.